Okay, councillors, we are now live on YouTube. So for the benefits of the public, I'm James Edmonds. I'm Democratic Services Assistant Manager at Northamptonshire County Council. The reason why I'm starting the meeting today is that we have apologies for non-attendance from the committee chairman, Councillor Scrimshaw, with Councillor McGee substituting for him. So in that situation, it's necessary for the committee to appoint one of the three vice chairs, who are Councillor Perry, Councillor Stamborough and Councillor Hakewill, to chair today's meeting. So if I could invite a nomination, please, for one of the vice chairs to take that position. And Councillor Perry, I have a hand up from you.
I'd like to nominate Chris Stamborough.
Okay, and is that seconded?
Seconded, yeah.
Okay, I'm seeing various indications. I'll take Councillor Hakewill as the seconder, and I have to ask, are there any alternative nominations? Although given that two of the vice chairs have seconded the other one, that rather narrows the field. So I see no indications of alternative nominations, in which case Councillor Stamborough as a vice chair is appointed to take the chair for this meeting.
Thank you very much, everybody. I hope your confidence won't be misplaced. So firstly, could we have some apologies for non-attendance, please?
Through you, Chair, as I say, we have apologies for non-attendance from Councillor Scrimshaw, with Councillor McGee substituting for him, and no other apologies.
I'm also aware, James, of Councillor John Eakins, who may be with us later, but was detained on business, I think, overnight, so may not be with us later. So if his apologies could be noted too. Thank you very much.
You,
so, James, have we got any notifications of requests to address the meeting?
We have none, Chair.
None. Good. Declaration of members' interests. Any councillors want to declare any disclosable pecuniary interests or non-statutory disclosable interests on items on the agenda that are not already listed in their register of interests? Can't see any hands up, so we'll move on. Chairman's announcements. Firstly, can we welcome everyone who's participating in what is the third remote meeting of the committee to be held under the new regulations that have been in place since April 2020. I'm sure members will be patient, and that will be welcome as the committee gets used to this new way of working, especially your chair today. The order of business for the current meeting reflects the fact that the Director of Children First Northamptonshire will only be able to join us at 11:30 because of other commitments. That's why we've got things in the order we have them today. Thanks to those who have joined us from the beginning of the meeting, and welcome to our guests. I think you would probably want to join me in sending our best wishes to Councillor Mick Scrimshaw, who can't be with us today. Mick's not very well at the moment, and he's undergoing some treatment, so he'll be out of the loop for a while, but I'm sure you would join me in hoping that he'll be back with us very soon. So best wishes, Mick. In addition, could I just give you a bit of a steer as to how I hope the meeting might go? I would ask councillors to keep to the point, try to avoid making speeches or giving us anecdotes, and ask pertinent questions, please. Once you have the floor, it's yours until you stop, or I think you've gone as far as you can with your line of questioning. You can come back in later, but only after those who haven't spoken previously. We're going to try to keep to time, but we should recognise that good scrutiny takes as long as it takes. Please, could you use the blue hands in the participants tab to indicate that you want to speak? And if for some reason you're unable to do that, put your hand up on screen if you can't. Don't put anything in the chat because that won't be monitored for people who want to speak. Thank you very much. Hopefully we'll have your understanding on all those points. Can I move on to the minutes of the Overview and Scrutiny meeting held in public on the 29th of July? You've seen the minutes. I'll just go through them page by page to see if anyone wants to raise any points of accuracy. So page 5, page 6, page 7, page 8, page 9, and page 10. So if everyone is happy with the accuracy of those minutes and there'll be no amendments raised in advance, please can we show of hands on screen, I think, to agree those minutes. Lovely, thank you very much. I think those are agreed, James.
Thank you, Chair.
So we will move swiftly on then to our first substantive item, which is health services in Northamptonshire. And this is very much around scrutinising health service. Oh, hello, sorry, Jill.
Before we move on to that, on the page 7, it says about the amount of the payment for the external audit. I didn't know whether we had any update on that.
I'm not aware of any update. I think questions have been asked in other forums about this, and the information that has come back is that pretty much as in the answer there, I think, not yet agreed, may be challenged by officers. So we await developments, I suppose, on that one.
Thank you. Okay.
So if there's nothing else, I've got Cecile. Cecile.
Yes, I was at the audit committee. No development. The account haven't been signed for 18-19 and 19-20, but everything is progressing, and it's up to the section 151 officer and the audit to progress. And I'm sure now the timeline is December, if I understand correctly. And that is all what we know, and we have no more information about the fees. Thank you.
So we will await developments then. Lovely. Right. Let's move on to the first substantive item then, I think. Can you put your blue hand down, please, Cecile? And our first substantive item is, as I'm saying, health services in Northamptonshire. And this is about addressing our health scrutiny responsibilities so that we can ensure that we carry those out as we're required to do. So, as I say, we're formally responsible for doing that, but in practice, we've been focusing on financial matters, as I think we've been directed to do, but we ought to address this part of our remit, I think, from time to time. So we've got, I think, 3 representatives from the NHS with us today. We've got Bev Messenger, who's the governing body lay member for patient and public involvement and lay deputy chair at, I'm not quite sure where, but we'll find out in a minute. Alison Gilbert, who's director of transformation and delivery, and I think I saw Toby Sanders, there he is, who is chief executive of the CCG. He's nodding, that's good. So we've got 3 people with us. If I could just say very quickly that we've got an hour allocated for this on the agenda. We've seen your presentation in advance. What I'm hoping you can do is pick out the points you want to emphasize and explain, and particularly slides 16 on pages 16 and 17, if you can say a little bit about those. But give us plenty of time to ask you questions, because I know that members have questions they would like to ask. And members, if you could hold off with questions until the end of the presentation, that would be really helpful. So thank you very much. Over to the NHS.
Chris, hi, it's Toby. I shall make a start if that's okay, sir. Thank you for inviting and giving us the opportunity to come along and have a conversation with you today. I agree, Chair. I think that the value here will be in the discussion rather than us broadcasting to you. So we will try to keep this element of it brief. The 3 colleagues that you've got in front of you this morning, myself, I'm the Chief Executive of Northamptonshire. Clinical Commissioning Group, NHS Northamptonshire. I'm also the executive lead for the Health and Care Partnership, which we'll talk about a little bit later on. Two colleagues, also colleagues from the Clinical Commissioning Group, Bev Messenger, who's our deputy lay member, and Alison Gilbert, who is our transformation director and supports the lead director for our Health and Care Partnership work as well. You'll sense from that, Chair and colleagues, that you've got three clinical commissioning group folk in front of you today, but we are here very much from a system perspective to talk to you about what the NHS is doing across Northamptonshire in the round at the moment. Happy to take comments or questions on any aspect of the things that we're going to touch on. We weren't entirely clear, Chair, the particular emphasis you wanted us to come and speak around. So the slides we put together are more a bit of a placeholder, if anything, as an introduction. So we'll canter through a few of those, but then happy to come back into any areas that you and your colleagues would like to explore with us. So I will start us off if that's okay. Is it possible to share on screen the slides we circulated, or would you like me to just refer to them as I go along? I don't know how you work with your Zoom format.
Is that James, or should we all look at our bits of paper?
We are set up for screen sharing, so Mr. Sanders should have the permission to do that.
Oh, that requires me to. That might be beyond my technical capabilities.
Okay. Bear with me. I will attempt to do the necessary.
One thing I should mention, when we as councillors will probably refer to page numbers, which are the page numbers of all of the documents in our pack, which may bear any relation whatsoever to anything you've got, which is just your presentation. So if it's unclear which page we're talking about, please say so.
Splendid. And it looks like we have something on screen. There we go. So is it okay, James, I think, isn't it, who's controlling the slides there? If I just ask you to just next slide as we move along, please. So if you could move me to the next slide, please, which I think is slide 12 in your packs. Excellent, thank you. So this is a visual representation of the core kind of areas of focus for the Northamptonshire Health and Care Partnership in terms of the areas, and we were asked to say a little bit about the priorities and the areas of focus for the NHS and the wider health and care system. So just as a recap for colleagues on the meeting today, the Northamptonshire Health and Care Partnership is a partnership that brings together the NHS, it brings together adult social care, it brings together children's services, it brings together the voluntary sector, it brings together independent providers. So it's the county-wide group that comes together to look at the health needs, the health challenges, the priorities and the aims that we need in terms of improving services for local people and patients across the county. And what's on screen here are the 5 aims and the priorities that we set down at the start of this year as a partnership, actually before we went into COVID. So this is kind of predates where we are from March onwards. But what's been really interesting over the last 6 months or so is that actually the areas that we were focused on as a system around improvement in terms of patient experience and outcomes and quality of care have very much been the same things that have come to the fore in terms of some of the pressures of responding through the pandemic phase as well. So just to, I won't walk through things that you can read yourselves and will have already on the screen, but we wanted to start off with that because it frames the kind of common goal and objectives that we've got, which are very clearly set out in terms of that plan for us as a health and care partnership. Next slide, please. This slide touches on one of the other areas that you're interested to get a bit of an update from us around, and this is some of the organisational change that has still actually happened during the midst of kind of pandemic response. So many of you will be aware that across the county over the last 6 or 7 years, the NHS has run with 2 clinical commissioning groups, one for NEN and one for Corby, and those 2 groups formally came together and a single new organisation was established on the 1st of April this year. So literally 2 weeks after we went into major national incident response around COVID and pandemic response, we still carried on and completed that transition to create a new single commissioning organisation for the county. I think that's relevant for 2 reasons in terms of this conversation. Firstly, because it's given us the ability to look at a county-wide level at health needs at the strategic commissioning kind of function in terms of how we plan and commission and fund healthcare services, looking at the whole of our population. And secondly, because part of that national direction towards bringing commissioning groups together into slightly larger units was intentionally about being able to release resource, financial resource, back into frontline care and being able to reduce some of the costs associated with that. And I'm pleased to be able to say that we've delivered on the cost reduction requirements as part of that national programme and that transition towards creating a new single organisation. You probably won't have seen too much kind of publicly and visibly yet that's Northamptonshire CCG branded, and that purely reflects the fact that the last 6 months we've all been very much preoccupied and focused on other areas rather than organisational form change. But we thought it was important to acknowledge here today from a scrutiny perspective, because I know it's something we've talked with you guys about in the past, that step in terms of change within the system has been concluded during the midst of this very unusual period. Thank you. Next slide, please. We've then got a number of slides which summarise and draw out some of the key issues around work in terms of health and care integration. So again, this was one of the areas that you were interested to understand a little bit more around. We've been working really closely, not just with the county council, but also with districts and boroughs and with the voluntary sector around the wider integration of health and care at a much more local place-based level. I think one of my colleagues on the line, Ali Gilbert, was intending to talk and speak to this part of the agenda, but Ali, I think you texted me to say you're struggling to be able to let Zoom help you speak. So I'm going to keep going, Chair, if that's okay. And Ali, if you do manage to find your way back in and are able to speak, then please just interrupt me. So a little bit about health and care integration. You were interested in what's happening around national policy for health services at the moment. This is absolutely the sort of single centre stage focus from a national NHS policy point of view. It's around how do we move away from a world where lots of individual NHS organisations that are their own statutory bodies operate in a fairly independent way to something where at a system level, and for Northamptonshire, we talk and think about the county level in that sense, to move to a situation where those organisations are very much working together, absolutely in the best interest of local people, of supporting staff, of working with other partner agencies, effectively in a kind of group model, but across different organisations working in that same patch. And in particular, and you mentioned, Chair, at the start of your opening remarks, finance and use of resources, in particular looking at the NHS budget in the round, rather than looking at the little bit individual bits of money that go into different parts of the system. And we don't have a slide which is on the money, but it was one of your questions. So just to give you a quick sense of scale of when I talk about an integrated care system for Northamptonshire, from an NHS funding point of view, what are we talking about? Well, my organisation now, the Single Commissioning Group, is responsible for about £1 billion worth of expenditure on an annual basis. And of that £1 billion worth of expenditure, a bit over half of that gets invested and spent within acute hospital care. So about 58% of our budget last year, 585 million, was spent on acute hospital care for patients registered with GP practices in Northamptonshire. That, of course, includes care that we fund for Kettering Hospital and Northampton General, but it also includes quite a significant number of our patients who rightly choose to access care out of county providers. If you're down in Brackley, you're much more likely to look towards Oxford. If you're up in the top end of the patch, you're much more likely to look either into Leicester or to look across into Peterborough and some of those surrounding areas. So we fund care for patients from an acute perspective wherever they access it, and a bit over half of our budget gets spent as a county in that area. Other couple of big areas of expenditure in terms of our budget, of that £1 billion, we spend about 14% of it on primary care services, so about 135 million. And that includes funding the 70-odd GP practices we've got across the county, but it also includes funding the prescribing through those practices in terms of community pharmacy, local prescriptions through GP practices. Really important service area around mental health that we've been investing in increasingly over recent years. We spend about £100 million on mental health services across the county, about 10% of our budget, and then about 8-9% of our budget on wider community services, typically services that are provided by Northamptonshire Health and Care Foundation Trust. So about £85 million we spend with them on things like district nursing services, community nursing services, OTs, physio, dietetics, and so on. So that gives you a bit of a sense. And this whole integrated care system piece that you'll hear us talk about is really how do we bring the different organisations that are responsible for providing different elements of those services together in a much more connected way. Next slide, please. This is quite busy. There's quite a few words on here. They give a bit of a summary, though, of a number of things that we've already made good progress with across Northamptonshire over the last year in strengthening the way that we work together in that healthcare system approach across health and care. And just to pull a couple of highlights out of this, I've touched on the commissioning group side of things, but really important developments for Northamptonshire in terms of the acute group model. Many of you will be aware that our 2 acute trusts are now working together in an acute group model. That means they share at the moment a shared and same chairman in Alan Burns and the same chief executive in Simon Weldon, who was formally appointed into the NGH role earlier this summer. And the 2 acutes are working through a process of strengthening, both from an executive, a clinical, and from a lay perspective, a non-exec perspective, a number of other shared roles and appointments across the 2 sites. I think this is a really good move for the county. I think many of you who've been in Northamptonshire a good few more years than I have will know there's been a long-standing kind of, I won't say tension, but a long-standing sort of dialogue between the 2 acutes about which services are located where, about how do we make sure we've got enough critical mass of cases in the 2 sites and the right clinical expertise to support patients with particularly some of the more specialist care that's required. And I think the group model is going to allow us to look at that on a larger population. And I know Alan and Simon are really up for doing that and having a broader public conversation about the implications of some of those things. What else might I pick out from this slide? I think the other piece I pick out here actually will be around the links in terms of local government reform, a world that you guys understand much better than I will. Although we've been working really closely alongside Teresa, Anna, David Oliver from the districts and boroughs around the arrangements with the unitaries and how the opportunities there in terms of a focus on place can really be strengthened. And I've got a couple of slides in a minute that touch on some of that. So I think at that point, I'll move on from this slide if I can, and we'll come back to some of those elements in discussion, I'm sure. Again, a reasonably busy slide here, but this sets out, if you think about the programme that you've been running for Future Northants in terms of the unitaries, you had a whole series of work streams all coming together in order to make sure you can affect the change that you want to see happen. This slide is an attempt to kind of depict an equivalent for the work we're doing around health and care integration through the Health and Care Partnership as part of that move towards integrated care status. And it captures 5 different pillars, if you like, within this. A huge focus on learning from our response to COVID and to the pandemic and to the ongoing learning and response into all of that. Secondly, a focus on system leadership and architecture. Some of you, for example, will be aware that over the last couple of weeks, we've been interviewing for a new independent chair for the Health and Care Partnership, really important role to bring together all of those different agencies. And I've literally come off the phone this morning from a conversation with our regional director about the next steps in that process of confirming that appointment, which we should, with a fair wind, be able to do in the next week or 2. Big focus in terms of pillar 3 there around population health management. And this is very much the link between the public health teams and Lucy Whiteman and the great work that her team does from a public health perspective on how we really understand the health needs and issues and challenges and opportunities that our local population face at all different levels of place across the county. I've talked a bit about pillar 4 in terms of strategic commissioning, and that 5th pillar around integrated care delivery. This is really where it kind of happens in terms of the delivery and the implementation across the county to improve services for our local residents. And a focus here on 3 different levels of place. And we've got a slide coming up next, which just illustrates that a bit more graphically. So if we could move on again, please. Next slide.
There we are.
Splendid, thank you. The reason this is, look at the left-hand side rather than the busy words in terms of the bullet points here, because I think what's interesting here is it shows graphically, geographically, how we're working in a different way across Northamptonshire to wrap and tailor service provision around individuals, then around very local network levels at neighbourhood level, around how we then do the right things that we can deliver sensibly working together, particularly with the unitaries at what we're describing as an integrated care partnership kind of level, and then how at that overall county-wide level there are some functions that we think from a health and care perspective it makes more sense to hold together in terms of the way those things are planned and delivered. The important message on this slide, though, is that we're absolutely committed to evolving and delivering as much as we can at a very localised level. And that's the reason why the primary care networks that we have across the county, which are groupings of general practices, working together in a group way, together with the voluntary sector, together with social care, together with community nursing teams. There's a huge positive momentum around those primary care networks and really moving to a more preventative, early identification, proactive care approach to supporting people, particularly with long-term conditions and frailty. And then secondly, at the unitary level, there's a whole host of things that we've been working alongside the blueprint work in terms of the unitaries to look at how we can do things, particularly around aspects of continuing healthcare, around care home provision, around some of our community services and how they link in with adult social care support. And at the overall county-wide level, we're really talking there about the planning function, about the objective and priority setting function, the kind of resource allocation function, to be able to devolve as much of the ability to get on and make change and improvement happen and manage those resources at a more local level into those other different levels of place. So we're talking very much here about a nestled set of different geographies working together across health and care to support people across the county, wherever they live. Thank you. Next slide, please. I'll refer, oh, there we go, we've caught up. We were asked in terms of some of your bullet point briefing to touch on any areas of kind of national government policy that are impacting on what's happening, particularly across the county at the moment. And this is refers to the main area of national policy around the move towards what I've already touched on in terms of integrated care systems. There's a national drive and policy direction for all parts of the country, and there's about 44 of these different ICS geographies across the country. The national direction is very much for all parts of the country to have achieved that status by April next year, by April 2021. But we're really clear locally in terms of our work with local government partners, the voluntary community sector, that this is a journey that we're going to be on way through into April in 2022. So what we're trying to do is put in place the building blocks to allow us to work together in more of a collective way, more of a stronger partnership way for next April, whilst then continuing to develop and build things out over the following period. Thank you. Next slide, please. I shall turn to something a little bit different to draw to a conclusion the few slides that we put in. I think we've gone the other way. If we could just
sorry.
That's all right. Brilliant, grand, thank you. So last slide, and just touching on what's for all of us has been very much our world over the last 6 months. So much of what I've just been describing is some of that medium to longer term piece around health and care policy, the priorities and focus for us within the county, and some of the changes to support that happening. But of course, over the last 6 months, we've been heavily focused on pandemic response in terms of COVID-19 management. I'd just like to say here for the record that as someone who started off chairing the system coordinating group and was sort of very much in the mix of the multi-agency response to this over the first few months during April, May, June time, that I think the support across all sectors has been tremendous across the county. I think the way that local government, that policing, that fire, that the voluntary sector, a whole host of other agencies, including and across the NHS, have come together and continue to, has been an absolute strength. And in many respects, one of our learnings is that it's accelerated some of that partnership and system working, albeit out of absolute necessity to respond and keep people safe and protect service capacity. But in terms of where we are from a health and care perspective at the moment around COVID-19, many of you on this call are involved in other forums, so I shan't repeat the kind of detail we get in things like the Oversight and Engagement Board. But from an NHS perspective, the focus really is on two areas. Firstly, restoring as many of our pre-COVID, of our non-COVID services to pre-COVID levels. So in simple terms, how do we make sure that we're restarting and recovering and making headway into the backlog for elective procedures, for outpatient procedures, for diagnostic tests? How do we make sure we really start to step back up in terms of screening, in terms of cancer treatment? We didn't stop any of those things around cancer and screening as we went through the first wave of COVID, but we did see a significant drop in presentations, particularly for things like cancer, strokes and heart attacks. And therefore, we've got an absolute focus across the system on trying to bring people back into services that are there to support them, as well as trying to tackle and address what have inevitably built up in terms of those backlogs around elective care and around planned treatment. So the first big focus at the moment is on using the period we're in at the moment, where thankfully we still locally have most of our hospital capacity able to be focused on non-COVID services, to be able to treat and to be able to support care plans for people for non-COVID activity. Second big area of focus, though, won't be any surprise to you guys, which is working with multi-agency partners at the moment through the oversight arrangements we've got, through the strategic coordinating groups and the local resilience forum, in order to put in place and strengthen our plans for what we are inevitably going into locally, which is seeing increasing cases of community transmission in cases that will almost inevitably translate, as we've seen in other parts of the country and in other countries, into increased pressure back into more health and acute healthcare services. As I say, just to be clear, as we're sat here today, we still have very low numbers. I think from looking at my latest daily dashboard in front of me, we've 12 patients across the 2 acute sites in Kettering and Northampton that are COVID positive confirmed, and another 20 or so that are kind of query COVID. But if you go back to the kind of peak of the first wave in May, that number was running closer to 200 at any one point in time. So we're in a decent place. We've got some really strong plans in place, but the infection prevention and control requirements inevitably mean that throughput and capacity, as with almost all sectors across the economy, is down on what we're normally able to run at. And that is presenting real challenges in terms of restoring services and getting back on top of things like elective care and elective activity. I think at that point, Chair, I'm probably going to pause. We've walked through the slides that we put together. I hope some of that touches on areas that you were interested in, but I'm really much keener to get into a conversation on any of those topics or other areas that you might like to explore with us. And I would say 2 other little messages before I open up. Our GP chair, Jo Watt, would have liked to have been with us today, but Wednesday's one of her GP in surgery days in practice in Corby, where she works when she's not with the CCG. So she couldn't be with us today, but it's great to have Bev with us. And secondly, if there are areas that you're interested in more detail around particular health services, whether that's hospital services or community services or mental health, that we're not able to answer today, we'll either follow those up for you or arrange for further conversations to happen at future meetings. Okay, I shall pause there. Thank you.
Thank you, Toby. We've just temporarily lost our chair. He's just rebooting at the moment. So I'm stepping in. Thank you very much for that. Before we go to any questions, do any of our other guests want to add to that? No, we happy with that? Okay. Right, so we'll go to open the floor for questions. Right. So I'll have to ask these in the order I saw them ping up. So I've got Councillor Birch, please.
Thank you very much. And thank you very much, Toby Sanders, for gallop through this restructuring. I'm particularly interested in the neighbourhood levels of delivery, and this seems to be an emerging pattern as we move towards local government reorganisation, that the neighbourhoods and local communities need to have that contact with the service providers. And I was wondering what area of your, is it the primary care networks that will be dealing with this? Who will take charge of this local community level delivery?
Okay, great question. Are you happy for me to just answer as we go and then take other questions, Chair? Yes, super.
Absolutely. Just, answer each one as it comes along.
Okay. Thank you, Councillor Birch, for the question. Yes, primary care networks are the most localised level. So we have 16 of these primary care networks across the county. They're groupings of GP practices in the main that have come together. Again, this is linked into national policy, so other parts of the country are moving in the same direction. And typically they're kind of 30 to 50,000 kind of population level in terms of the number of patients that are registered in that area. So it is a pretty localised level of provision. And at that level, we've been working really closely with Anna Earnshaw's team from an adult social care perspective, with Northamptonshire Healthcare Foundation, particularly around services like community nursing services, and supporting those primary care networks that have got funded and appointed clinical directors, for example, to be able to work in a more multidisciplinary way across those teams. So they're actively managing and supporting local people on effectively a shared kind of caseload between them in terms of how they're providing services and supporting people in a more connected way. It's still relatively early days. It's still variable. We've got some of those primary care networks that have really flown, and they've had the capacity and they've had the resource to be able to do that. We've got others that it's fair to say are still finding their feet a bit more. But certainly we've got some great examples already across the county of how some of those things are working in practice. Of course, that's been impacted on a bit by the last 6 months. Most of our practices are doing heavy amounts of virtual working in the same way that we're all getting used to working in this way. But we're still, again, seeing real momentum through that. I think particularly the support to the shielded population through the early wave 1 of COVID really helped to accelerate some of that, because we saw connections between particularly voluntary and community organisations and local healthcare teams in a way that perhaps we haven't seen as consistently across the board.
Councillor Birch, do you have a follow-up question at all? Or are you happy with that response?
Very happy with that. Thank you for your full answer.
Councillor McGee next. Thank you.
Thank you, Chair. I hope Chris is managing to get back in soon. But Chair, I've got several questions because I wrote them down as I went through the paper. So shall I just read them all out, and then hopefully, rather than try to get one answer on all these questions, we can get it at the end? Is that? I think that would be easier, Chair, would it not?
Yeah, that's that. If Toby's happy with that, that's fine.
Okay, Chair. On the page 14, you've mentioned joint commissioning, and I'm glad that the Northamptonshire Health and Care Partnership is working together. Does that have a commissioning arm to look at? Because I know we do some very good work with joint commissioning, but we need to do more if we truly want an integrated care system, and that's across all partners. So can you give me examples of where it is now and where it's going to, please? On the acute, the agreed the joining of CCGs, I, for one, as a Corby councillor, didn't agree with that. I think we lose localism, but it's there, and we work with that as much as possible. How much savings was made from that joining together, and how much of that has went directly into frontline services, please? And one of my things that I've raised constantly is the health inequalities, and it's mentioned in your slides quite often. The health inequalities or the life expectancy in Corby is dramatically different from anywhere else. How as a joint group are we going to ensure that we can improve that? It's been like that for some time, and it'd be nice to see some positive change. I agree with the PCNs, the primary care networks, but on your website, Corby isn't mentioned. It comes under Rockingham Forest, and given the special needs and the health inequalities in Corby, I find that a bit strange. And can you explain why? I'm sure it's nothing to do with numbers, etc., and outcomes at the end of it, but I would really like to understand why that is. Congratulations on getting the money for the Kettering J Hub. I think that's absolutely fantastic. It's great news. And it does mention somewhere in the paper, Chair, I just can't find it just now, about vehicles, mobile lung health trucks for Corby. Where are they, and when will we see them on the ground? Chair, I do have other questions, but I'm going to end there so we give other people an opportunity to ask questions.
Okay, thank you, Councillor McGee. I will try to canter through a response to the areas that you've just listed out, and to be as brief as I can to give other people a chance for questions. So your first question was around joint commissioning, something that I'm really absolutely committed to, and something that I think this set of changes that I was outlining around working at different levels of place helps with. So give you a practical example. If we look at our commissioning of services from care homes in particular, my organisation funds quite significant packages of care for people in nursing and care and residential homes across the county, as does Anna Zernshaw's team from NCC, and in future going forwards, the two unitaries, of course, will through their own adult services teams. We, as over the last 12 months, have strengthened the work we're doing joint in that area. So moving to a joint approach around brokerage in terms of how we place people into homes. moving towards the alignment and consistency for funding tariff arrangements, which is something we've always had a big variation across health and local government, which has distorted the market, to be honest, in places in terms of how people respond to that. And we think harmonising that is a really good move. And then really importantly, a joint approach in terms of quality framework and quality oversight in terms of how we then work with those homes, the expectations of them in terms of delivery and consistent standards, and also being able to jointly support and prioritise improvements in particular areas. So not surprisingly at the moment, a lot of joint work around infection prevention and control, around training and support for care home staff in terms of those areas. And that's something that at the moment we've moved a long way. We've got joint teams at the minute that are physically sat side by side at One Angel. And going forward, I'm expecting to see more of that as we work with the two unitaries. And I think that's the reason why that diagram I put up with 3 different levels of maps in it almost. That unitary footprint, I think in the future is going to be so critical to what we do. This isn't about everything being done for the NHS at a single kind of county-wide level. That's not what this is about. It's about trying to do as much at unitary level and as much at locality and primary care network level as we can. You touched on the CCG changes and the moves there, and asked a specific question around savings. So we reduced our running cost budget by 10% as we went through that period. And that's money which, in terms of your question of does that get reinvested back into other areas of healthcare, my organisation is funded by government. I get 2 allocations and they're both fixed and ring fenced. The vast majority of that £1 billion a year is to fund healthcare services. I then get a separate allocation specifically for running the organisation that administers that. That allocation is reduced over time in real terms by that 10% change, and we've taken that out. But what we've seen on our overall allocation for funding healthcare services has increased. So it's not a straight one goes into the other. What we have seen is a recalibrating, if you like, of that. So we've done what we said we would do. We've taken out and released that level of fund, and we've been able to then focus more on that side of things. But it's not one big pot that I can then take money from one and place into the other. I hope that makes sense. It's a typically NHS financial view of how those things work. You touched on health inequalities. Couldn't agree more. We've got, Northamptonshire is a county of huge contrasts across it in terms of inequality, in terms of deprivation, in terms of life expectancy, in terms of health outcomes. And that's really why the focus on different levels of place is so important, because I absolutely appreciate, and you and other colleagues were very contributed to the discussion about single organisation for commissioning and moving away from the Corby CCG. I've been really committed to not losing the local focus in all of that, which is why the PCN and the locality level is so important to what we do from an inequalities point of view. And what we're supporting those primary care networks to do is for them to identify the health issues and challenges in their local areas that are important to them, rather than us dictating a kind of single consistent approach across the whole of the county. And we're already seeing that resulting in a different area of focus in Daventry to Corby to Wellingborough, for example, that reflects the issues that have been faced in local areas. I have to say that at the moment, from a health inequalities perspective, my real bigger concern over the last 6 months has been that we will inevitably have seen a widening of the health inequalities gap across the county as a result of people's differential experience and impact of COVID, both in terms of what we know about how COVID impacts differentially on different communities in terms of incidents and outcomes, but also what we know for people and patients accessing other healthcare services, which again, that kind of inverse care law has not changed over locally and nationally over that period. So we know that people will have struggled to access services more from some of our more deprived communities, and we're working very hard to redress that balance to make sure that doesn't drift too far. But I think if anything, my inequalities concern is that will have locally and nationally widened over the last 6 months, and the NHS nationally, regionally, locally is focused on working with partners to try and address that. Last couple of quick comments. You touched on the primary care networks, and I'm just looking at my notes and the groups within those. Your question was about Corby, wasn't it? Why have we got Rockingham, and why have we not got a Corby? Corby's actually got 3 primary care networks that cover parts of it. If you zoom in on that map, they're actually overlapping in terms of geography. The reason for that is that this national initiative around primary care networks was encouraging, I suppose, what I'll call coalitions of the willing to work together in terms of GP practices, to work at a scale that was bigger than just their own practice, But when you start to get to 30 to 50,000 population as being the kind of defining number, it was about practices that were up for working together. And we all know so much about change and improvement comes down to relationships and individuals and mindset and how organisations work with each other. And so that reflects the reason that when you look at some of that PCN map, it doesn't look like the kind of neat thing that a bureaucrat might draw if they were trying to do neat, tidy edges. It reflects real world messiness, which is the relationships between practices and how they work together. But there absolutely is a focus across the whole of Corby, and all Corby residents are covered through one or other of those networks. And then your last question was a very specific point about mobile vehicles and acute hubs, and you'll have to forgive me, I'd need to go back to the slide deck my team put together to find the specific point. So I might try and do that whilst we're carrying on the conversation, if that's okay, Councillor McGee. Thank you.
Thank you, Toby, for that. And thanks to Councillor Perry, I think, who it was who stepped in when my laptop died because I committed the schoolboy error of not plugging the charger in. A lesson for us all there. Sorry about that hiatus. Thank you, Victoria. And I think our next questioner is Anjona Roy.
Thank you, Chair. Mr. Saunders, I just wanted to carry on from Councillor McGee's points around health inequalities, particularly the issues around, as you've stated, the increasing health inequalities under COVID. It would be helpful to find out a little bit more about, having identified these increasing health inequalities, what kind of strategies are in place to address these. I'm also concerned particularly around racial health inequalities, particularly in respect to COVID. I'm aware that the Northampton Communities Alliance were in communication with the General Hospital, who stated that they weren't doing ethnic monitoring of frontline staff, and this is again a particularly concerning issue. I think also in terms of some of the low-level stuff, a lot of this is not, a lot of the issues around health inequalities have direct links to poverty. There's some excellent work being done with the Food Poverty Network, and also certainly myself and Councillor Strachan were involved in a joint project last year, particularly trying to increase the take-up of the Healthy Start vouchers. This is one of the issues that will directly affect people on the ground who have limited access to food, and yet in order to get that, they do have to have that signed off by a health visitor. So think initiatives like that. We know Northamptonshire has a lower take-up than the rest of the country. And are there any kind of proposals to have action in some of those primary care networks to increase the access to try and alleviate food poverty?
Okay, thank you, Councillor Roy. Chair, shall I just jump in and respond to those points? And I'll also just sort of give a forewarning as well. I'm conscious Bev Messenger, one of our lay members and deputy chair, is also on the call. I think Alison Gilbert, one of my directors, had to drop off and was struggling to find a way back in. But Bev, if there's anything that you'd like to add into any of what I'm describing, I'm conscious that I'm doing a bit of a one-man show at the moment, so please do feel free to chip in and join as well. But to respond, Councillor Roy, to the questions that you've raised, I'll deal with the second of those first, in terms of the question around ethnicity and around race and around the differential impact that we know there's been from a COVID perspective. There's been a very strong national focus in terms of BAME communities and the focus on how we make sure that we identify both staff and members of the public who might be more at risk as we go through this period. I know that all of the local NHS organisations, my own included, and the two acute trusts, as well as Northamptonshire Health and Care Foundation Trust, have at individual staff level, from a staff perspective, carried out risk assessments with all of our individual employees in order to make sure that we understand not just people's risk factors, but actually as much anything that we understand where people are at in terms of their own levels of concern and anxiety around things, because one thing that we've absolutely seen through this period has been the impact in terms of mental health as well as physical health responses caused by anxiety, concern, and that's differential for all of us in terms of how we respond to things. So I know that from a staff perspective, there's been a big focus on how do we support staff, how do we identify people that either might be at greater risk or the people that might have particular levels of anxiety and concern around how their COVID experience is impacting on them. And we've also undertaken things over the last couple of months, for example, like a big joint system piece of work around our staff wellbeing festival that some of you might have heard of. It was extended as an offer to social care staff as well as health staff across the county. And that was a virtual week of events and talks and activities to support people from a staff perspective in terms of how they respond and cope through COVID. From a wider public perspective, in terms of health inequalities, you're absolutely right, Councillor Roy, the primary care network level is the level at which we've been working to identify and support patients in those local areas who we know might be more at risk. If you look back at the first wave response to COVID, we saw a tremendous response through the identification of people on shielded lists and being able to support them. And much of that was around providing kind of activities of daily living sort of support and providing people with access to food and to medication as well through that period. I think you made some really interesting comments around food poverty, which I absolutely recognise, and the variation across the county in that. That's something that I think would be a good to take away and reflect on, and perhaps pick up with you afterwards if you particular experience or thoughts you might like to share on how health and care could work differently in terms of working with some of those organisations. Thank you. Beth, is there anything that you might want to add in general to any of the above that I've described? I'm conscious, having invited you in to join us today, that I'd really rather not respond to everything as we go along. If you're right there.
I mean, I suppose because I've got two roles, I'm Deputy Lay Chair, but I'm also the Patient and Public Participation Lay Member. I was anticipating, and I may get a question around engagement and communication. So one of the things that we wanted to, leave a lasting impression of how not only have we got statutory requirements around engagement and participation, obviously we're very committed culturally as a new CCG to make sure that we deeply engage with communities about current issues and future plans, given the amount of change that you've seen that's in the presentation today, which will affect, all of your residents across, now the county council and districts, but in future the two unitaries. Now, in February we started a set of plans. So Lucy Whiteman is the CCG lead for communications, and Lucy and I work very closely together on communications and engagement with the public and patients, and had a whole series of plans that we wanted to go out and consult on and make changes to the way we engage and connect with communities and residents. And of course, it was just at the time then that COVID hit us in the sort of following month, and we've not been able to progress some of those as much as we would have liked to have done. But I suppose I just wanted to reassure you how committed we are to that level of engagement and participation. I suppose it links to Councillor Birch's question about that local neighbourhood delivery. We're really keen to make sure that we have those processes in place. It is trickier at the moment, obviously, as I'm sure you appreciate, and we're dealing with things on a sort of case by case, issue by issue basis, but we're hopefully not too far away from a whole new engagement strategy that we'll want to bring and share with the local authority, because obviously we see you as a critical part in that way of connecting with communities to ensure that their voice is heard in all of our decision making and all of our strategic commissioning activity. So that was more of a statement than anything else, Toby, but that was something that I was, very passionately wanted to get across in this call. That I'm really quite frustrated, as I'm sure everybody is, that COVID has blown off course really exciting plans that we've got to make sure that the new CCG and the rest of the system absolutely had at its heart patients, residents and the public, carers, voluntary sector. I could go on and on to make sure that everything that we do has got that real people focus at its heart.
Thank you very much for that, Bev. I think we'd all want to ensure that our residents are heard and that they have their say. And I'm sure we'll be letting you know if we feel that's not the case. So thanks for that. So Jonah and John, I'm conscious, did either of you want to come back on any of the answers you had, or can I move on to Councillor Michael Clark, who's next? You're muted, John. Still muted.
You got me?
Yeah, you're
happy to come in at a later stage, Chair.
Okay, lovely. I'll bring you back in later. So
Same here, Chair.
Okay, brilliant. Councillor Michael Clark then.
Thank you, Mr. Chairman. First, I was impressed certainly by the description of the way there is far more joint up working together in the health community and the delivery of services. Perhaps this has in part been prompted by the sudden emergency of COVID. Perhaps it was something that was happening anyway, but to someone who is always asking the question about, are we getting the best value for every pound of taxpayers' money that we spend, I am encouraged to hear that these various groups, which are seemed in the past always to be working in silos and some arguing with each other, that there is an outbreak of glasnost, and that you are all coming together, I think, in the common interests of the health needs of the people of the county. So I've really got two questions. One's concerning finance, and then the second one is concerning the unitary situation. You mentioned this figure very quickly, one sentence, that we receive or spend £1 billion. Could you elaborate a little bit more and explain to us, from your understanding, how this figure is arrived at? And where I'm coming from is that we in Northamptonshire have constantly felt over many years that as we are a growth county, growth in housing, population, jobs, and all these other things, we were being penalised by formulae applied from on high in London in financial allocations. So I wonder if you can perhaps share with us your understanding of how the £1 billion is arrived at. Is it through a dreaded algorithm? Is it through per capita allocation? Does it take account of the projected growth in the numbers of people in our county, which certainly was a complaint the County Council had over central government funding for the County Council in the last 10 years, that the formula applied never really reflected the growth in population. It only reflected census numbers, and those census numbers were out of date. So if you can perhaps share with us your knowledge and understanding, and also how often that £1 billion is negotiated. Is it an annual figure? How often is it up for renegotiation? Do you make a bid to central government for that money, or is it simply an allocation and you're told you've got to do the best you can with it, i.e. is it negotiable? Coming on to the second point on unitaries, clearly we are set on this journey following the Cala report and government consultation and decisions. We are going to be two, whereas previously we are a united county, as it were. Now we've got a children's trust which will be pan Northamptonshire, and we're looking interestingly later at how that's going to impact on its working with the two unitaries. But I wonder if you could explain how you see your work panning out with regard to the way you deal with the two unitaries. For example, are there any banana skins which you see coming down the road, as it were, problem areas which have got to be addressed, whereas previously you're working throughout the county of Northamptonshire? You're clearly will be working with two separate entities. Does that pose problems which haven't yet been foreseen? Do you foresee any areas where there could be possible difficulties, friction? And if you can, what steps would you like to see being taken by councillors, MPs and others to ensure we have a smoother transition as possible and we don't get any glitches further down the road? Thank you.
Okay, Councillor Clark, thank you for two extremely good but extremely full and complex questions. I'll do my best to touch in the time that we've got briefly on both of those. So firstly, on the formula side of things, in terms of the money, where does the £1 billion come from? How does it get to be £1 billion? How does that get negotiated, etc.? So majority of the funding that flows into the county to fund NHS services flows through my organisation, through the Clinical Commissioning Group, and that's the £1 billion I referred to. There is other funding that will come into the county in addition to that for services like specialised services, which will be things like, you know, complex trauma, etc., which are typically funded nationally by NHS England and funded in specialist centres. So when our residents go to Leicester Royal, for example, for complex cardiac surgery, there'll be elements of that that are funded through that route. But the vast majority of the NHS pound, if you like, that comes into Northamptonshire comes through the commissioning group and comes through and as part of that £1 billion or so worth of allocation. It is an allocation number. It's not something we bid for. It's a number which is built up on the basis almost of all of the above of the factors you described. So it's built up on a per capita basis according to the number of patients who are registered with GP practices that are part of our commissioning group. And that distinction is important because as a county that has quite a lot of border geographically, we have practices that are towards the edge of Northamptonshire geographically, but who will have patients registered over the border in surrounding counties. We receive allocation and funding for their care as well if they're registered with one of our GP surgeries. So the funding is built up, bottom up, from a population per capita approach. There is then a national formula that is used. Some might call it an algorithm that kind of determines and takes account or seeks to take account of a whole series of factors in terms of health inequalities, in terms of health need, in terms of deprivation. There is also then a factor applied into that in relation to population change and demographic change. But that is a looking backwards and a current position, as opposed to we don't receive funding prospectively increased on the basis that our population is going to increase by 30,000 over the next however many years. So it's a kind of up to a current point. Now, that's the formula and approach that's been used over recent years for funding health services. Just to be clear, though, in terms of where we are today and the last 6 months, this financial year has seen almost all of those normal arrangements suspended. We're operating in a very different environment where we have effectively suspended most of our normal contracting and financial flow arrangements. We've had national allocations being provided to areas based on their historic spend, and those funding levels are then being directly provided to our provider trusts and organisations. And in addition to that, we've been running effectively a top-up process around COVID expenditure, where on a retrospective basis, we've been submitting claims each month in the millions for additional costs that have been incurred by the NHS responding to the pandemic. And those have been funded to date from a national perspective. Those arrangements are changing from October going forwards, and will be given a local allocation to manage ourselves from within that pot. So there's almost a bit of all of that in answer to your question, Councillor Clark. Yes, there is a formula. Yes, it's population driven. Does it adequately take account of population change going forwards? Not until it happens. So the trigger point here is when patients' numbers increase on GP registered lists, as opposed to known house building that might be happening in the north of the county, particularly around Corby and other areas, for example. I might just pause there because I can see Michael on screen. Just in terms of whether that answers as much as I probably can at the time we've got the question around the money. I suppose the heart of your question was, does Northamptonshire get a fair deal in terms of allocation formula? From what I see and from other areas I've worked in, I've not been campaigning or lobbying regional bodies to say Northamptonshire doesn't receive the level of funding that is reasonable for the services that we need to provide. I don't think that's our biggest rate limiting step within the county. That's not to say we wouldn't always like more. Your second question was around unitaries and around children's trust and issues that we might see in terms of working with the unitaries. I'd say I've been a bit pleased to have been kept closely involved by Teresa Grant, by Anna Earnshaw and others alongside your kind of blueprint developments. So this is a personal view rather than necessarily a corporate or an NHS view, but from a personal perspective, I can see some real opportunities and strengths around how we work with the two unitaries at a more local place-based level. We've talked about some of that around things like how we work jointly around care homes, for example. I think there are also some things that have emerged and crystallised for me in my mind throughout the pandemic response that I would very much like to see us find a way to hold together at a county-wide level. And in particular, I would point to the business intelligence work that the public health team and Lucy Whiteman's team have jointly been able to do. Lucy holds a shared post. She's seconded to my organisation half-time as well as her DPH role. And with my organisation, she holds the brief for our business intelligence function in terms of our analytics, in terms of our health need assessment function. I think there's an economy of scale and of skill and expertise in doing something like that once, but doing it in a way that supports the unitaries and supports the primary care network level. So I don't think it's about doing it all in one place or somewhere else. I do think there are some functions, and particularly things like that business intelligence, population health management, health need assessment function, that I've certainly advocated in my conversations with Hannah, Teresa and others to see held together on a joint basis with health, because I think there's some real benefits in terms of skill, expertise, critical mass and value for money. Inevitably working with two organisations moving forwards when, like me, you're running something that's county-wide, will present some challenges. I think they're things that we can work through. I think at the heart, it's about being clear about function and what gets undertaken at which level of place. So to give you, for example, health and wellbeing boards. I suspect we'll probably rightly end up having 2 health and wellbeing boards across the county, as well as a single health and care partnership that is county-wide. How do we make sure those things aren't tripping each other up and duplicating functions? I think for me, it's about clarity of purpose and about seeing health and wellbeing boards at a unitary level, bringing together providers focused on delivery in those local areas. But I would hope that we can still continue to come together at a larger county-wide level to look at some of the big strategic questions about the configuration of acute services across the county and how we respond to some of those pathways of care to improve outcomes for patients, where it makes sense to look at that at a larger 750,000 population level rather than the 2 unitaries kind of level. Thank you.
Is that okay for you, Michael? Those answers very full and comprehensive, I thought.
So far, so good. Thank you.
Lovely. Okay, so I've got 3 speakers who haven't yet spoken: Malcolm Waters, Jim Hakehill, and Cecile Irving-Swift. I'll bring them in that order. So, Councillor Malcolm Waters.
Thank you, Chair. Good morning to everyone. Can you hear me? Everybody got me? You got me? Right. Could I just divert slightly to the paper? Because I think it's time where we took up the general public's concerns about health. At the moment, we all know about the COVID-19. The comments say here, preparing for winter, which is a very good input into what I want to talk about, because for many, many years, we've been talking about bed blocking. Now, I should imagine with the COVID situation, that is totally changed, but you can update me on what the situation is on that element. People are concerned about the flu vaccinations. The media, the media tells us there is enough, that they scaremongering all the time. I think if it's possible for you this morning to enlighten us, so we can enlighten the general public that all these things are virtually scaremongering. We have in control the situation with the vaccinations. I call it bed blocking again, but I'm sure there's another word for that these days, because I think the general public need that reassurance at this stage of where we are. I hope that's not too much. You understand the questions?
Yeah, absolutely, Councillor Waters. Hello,
Thank you.
Can you hear me okay? Yeah, absolutely understand the questions, and they're 2 really, really good questions and very valid as well. I'll just take them in the order that you've described them. So in terms of what I'd probably describe as delayed transfers of care rather than the bed blocking phrase, but we all know what we're talking about. And if you go back pre-COVID, early part of this year and last winter, Northamptonshire was a real outlier nationally in terms of having relatively high proportionate levels across our 2 acutes in particular of patients who no longer had an acute medical need and therefore required to be in an acute hospital facility, but were struggling to be able to be discharged into or to return home with the right kind of support and package in place. To put that into numbers, at any one point over last winter, we typically would have had 250 or so patients across our 2 acute trusts that, from an acute trust perspective, they felt no longer required their level of more specialist medical support and intervention. whole host of complicated factors contributing to that, of course. Some of it about access and capacity in other services people are being referred into, some of it around support for packages of care and the process, whether it's a health funded process or a local authority adult social care funded process around continuing care and funding of nursing and residential care. Some of it around making sure that we've got the right adaptations in place for people to be able to return into their normal place of residence at home, etc. You're right, what we saw during the early period of COVID, during late March, early April of this year, was actually that 250-ish number just dropped to pretty much zero. As a result of most agencies suspending their normal kind of processes, the NHS took on the cost of funding people's ongoing care for a period of time through that. And we saw a massive focus on freeing up hospital bed capacity for what we were concerned was going to be an overwhelmed NHS with COVID activity earlier in the year. What we've seen in the following months is those numbers of delayed transfers starting to step back up again. We're nowhere near where we were in terms of those high numbers, but we are concerned locally about the trend that is starting to increase again. It's something we've been picking up and working very closely with Anna Earnshaw's team, with Katie Brown and with the social care team at the County Council, and also with the 2 acute hospitals and the community trust. And in fact, I'm meeting this afternoon with the chief execs and with Anna across those organisations, and this is on the agenda for our discussions. And we have a big programme of work that you'll hear us talk more publicly about under the brand of ICAN, Integrating Care Across Northamptonshire, which effectively is about how do we support maintaining that flow in terms of appropriate discharge into the right setting, for all the reasons that we know are beneficial, both in terms of use of resources, but actually the longer people stay in acute hospitals when they don't need to be, all the evidence tells us clinically people's condition further deteriorates. So it's poor for their outcomes, it's poor for their experience, and it's poor for use of resources. So it's not the scale of issue that we've had in previous winters yet across the county. But when I look at the winter we're going into and think about COVID, think about flu, think about infection prevention control arrangements that have reduced our capacity in our acutes, all of that points to, I think, a really, really challenged autumn and winter. Which is why flu vaccinations are so important, because the flu programme, as you rightly say, is one of the big strands of the national strategy in terms of approach at the moment. Lots of you, no doubt, will have had text messages from GP surgeries and others kind of inviting you to come in for your flu jab. This is going to be the biggest campaign we've seen on flu vaccinations for a lot of years. The question about capacity and have we got enough is a good one. From an NHS perspective, we are still being briefed regionally, nationally, that the NHS has got arrangements in place to be able to provide through the NHS route the volumes that we need. What is clearly an issue at the moment is community pharmacy capacity for people who aren't either within the age ranges or within the vulnerable risk groups that would automatically get an NHS funded flu jab. And so some of you are probably aware, I think, don't quote me on this, but I think it was Boots and Lloyd's last week took down their online booking systems for the public who might want themselves to go and get a flu jab and to pay for that to happen privately. And I think that's fueled some of the concern around supply. Clearly, that's not something the NHS is directly responsible for, but I think it's contributed to this public anxiety, which is entirely understandable, around have we got enough supply and security of that for flu vaccinations. But anything you are able to do as members of this committee to support that campaign around encouraging people to get the flu jab if they're entitled to that would be hugely welcome, because we think it's an important line of defence in terms of this winter.
Thank you very much. Thank you.
Thanks, Toby. Sorry, is that okay, Malcolm? Answered your question? Good stuff. Okay, Councillor Jim Hakewell then, please.
Thank you, Chairman. I'm aware it's 11:15 and you were targeting 11. So my questions, I'll just turn into statements given that Toby is here to listen. Firstly, really welcome the cross borders issue. Live in Northamptonshire, doctor's surgery in Harborough, and particularly during COVID, being told not to go to Leicester. So that worked very well. So I welcome that and commend the cross-border aspect. Are there exemplars, not for you to talk about now, but you could get to us, where health and social care have combined and done a great job somewhere around the country? And obviously through James in our democratic services, if there are places like that, I'd love to talk to one or two of the people in those areas, Chairman. And the third point, again, I want to make the point, but not expect an answer right now. One of the issues about someone being in hospital and getting better is the ability of their family and friends to get to see them when they can, obviously not within the constraints of COVID. By focusing on 2 hospitals, certainly rural, and we are very rural, dwellers who don't have access to a car can find that very difficult. So I really hope that in discussions with Unitary, there can be a return to some bus services, maybe even between the 2 hospitals, so that friends and relatives can get in to see people, as opposed to the issues of parking around both hospitals. So, Chairman, because of your timescale and because I've learnt my lessons of the past, I don't expect Toby to answer, but I hope you might just put a thumb up to say, taken on board and maybe some other time. Thank you, Chairman.
Thanks for that, Jim. And I saw Toby's thumb go up. So hopefully, as you've requested, taken on board, and he may come back to you outside the meeting. So if that's okay, I'll move on to Councillor Irving-Swift.
Thank you, Chairman. Good morning, Toby. One question, you touch on the sharing public health with County Council. Now, in view of COVID-19, do you think there will be a reshuffle of public health? Will it have an impact on the way we do things? Because I do believe that in the all with COVID-19, the preparation for the pandemic left us quite open to what we see now. So how are we going to do with public health and the new, because you have put in place sharing public health with Northampton County Council and after the 2 Unitary, how do you think that going in the future? Thank you.
Okay, thank you, Cecile. I'll reply to that if that's okay, Chair. So worth noting on public health that there's public health functions that sit at 2 levels. So you've got Public Health England, national body, responsible for a whole set of things from a statutory perspective, and then public health functions that are within and hosted within local upper tier local authorities. So NCC at the moment and the Unitaries going forwards. Nationally, there have already been statements made by Matt Hancock and others around Public Health England and changes to all of that. And we all, myself included, will wait and see where that goes. Locally, I have to say, I think we've been, and the pandemic response we've had to date has shown the strength of this, fortunate in having an exceptionally capable and strong public health function within Northamptonshire. I know when I talk to some of my colleagues in other parts of the country that our public health team locally, and Lucy in particular leading that, were heavily involved at the centre of all of our modelling, all of our demand activity planning, the work we did around critical care capacity, and now much more recently the work that's been done around test and trace and that whole sort of set of work. And I've seen through this last period the real benefit of Lucy's team and the public health analyst function working really closely, well, effectively working in a very embedded way. It's difficult sometimes to tell who works for who, which is a good thing, I think, working very jointly on producing the kind of intelligence and insights and data reporting packs that many of us receive at the moment on a daily, weekly basis around COVID. So my hope going forward, and it's a hope, Cecile, because I appreciate it's not my decision, it's one that the Unitaries will take, but I really hope that there's an opportunity to still keep some of that joint arrangement around health and public health and the NHS where it makes sense to do so. Not on everything, not on the kind of local delivery of some of the public health interventions and some of the local health prevention services, but at the level of planning, of needs assessment, of business intelligence, I think we would be missing a trick if we look back in 2 years' time and we'd allowed some of that to sort of step down from that. Personal view.
Is that sufficient answer for you, Cecile?
Yes, thank you, Chairman.
Thank you very much. Okay, John, I think you wanted to come back in.
If I may, Chair, I'm sorry, but this is the only opportunity we've had for over a year now to have questions on health. So thank you for understanding that. I'm not. Michael asked the question about finances a lot better than I could. I'm not sure I agree with Toby in that Northamptonshire gets its fair share given the health inequalities and the diverse population needs across Northamptonshire. It's so diverse, especially the public health is underfunded in Northamptonshire. I think that's just a fact. But my other question, Chair, is, and I make no apologies for labouring on joint commissioning. And Toby mentioned in his presentation about the voluntary sector. They play a great part in the prevention, stopping especially older people going into acute care, going to see the doctors, etc. And my biggest bugbear is that the funding for the voluntary sector is so difficult. We know public health within the next few months are going to be cutting a lot of the voluntary sector. And joint commissioning means for things like the Autumn Centre, we deal with a lot of older people and keep them away from services. They're threatening to be closed. Why can't we have a joint commission across NHS, public health, social care, and the local authorities to ensure the prevention agenda that the voluntary sector provides carries on during these difficult times? And my final question, Chair, is to Beverly. Beverly, I'm not going to mention individual cases just now because that would be totally wrong, but I have several residents who come to me and say, I feel so frustrated with my services from the local hospital or the doctors, etc. And trying to get, even as a councillor, trying to get replies is extremely difficult. How do we resolve that for the residents? Thank you.
Okay, thank you, Councillor McGee. And before answering your two questions, actually, probably worth noting, Chair, your comment about it's taken a year to get to sort of today's conversation. I wasn't aware that we've been trying to get a conversation like this set up for a while, but I'm more than happy, either myself or other colleagues, and it may be helpful if this committee thinks it will be useful for some of our colleagues from the acute sector and for community mental health services to join these sorts of conversations if people would find that useful going forward. So I'm very open to that. I'm conscious that we've crammed an awful lot into the time that we've had this morning and happy to come back again at a future conversation, potentially with some other colleagues. On the 2 points you specifically made though, Councillor McGee, the funding point, I guess my point was less that I'm convinced that actually Northamptonshire is absolutely equitably treated in terms of funding compared to need, compared to other areas. And more, I suppose, the point that I've seen far too many systems get so focused on whether we do or don't get our fair share that we don't spend enough time actually focusing on what we do with the £1 billion that we've got. And I've not actually worked in any part of the country that thought it was getting more than its fair share. I've worked in an awful lot of areas that I've spent a lot of time having debates about what they don't get. And the reality from an NHS point of view is if we don't live within our means, within that £1 billion, and let's be honest here, Northamptonshire hasn't been living within its means for the last 3-4 years, we've continued to be supported financially by the NHS regionally and nationally to cover the additional cost that we've spent. And that's evident in the fact that some of our local organisations run deficit positions in terms of overspending each year, in addition to the £1 billion we put in. So the reason for saying it from an NHS point of view is it almost becomes a debate that potentially is quite distracting. And actually, even if we fail to live within our means because we weren't able to, as a general rule of thumb, we'll focus on providing the support people need and then deal with the consequences of that rather than trying to unreasonably constrain service provision within a fixed financial envelope. And as I say, you can see that in the positions of deficit organisations locally. On the public health point, my comment about funding at formula and allocations was very much an NHS funding question rather than public health, which is obviously rooted into local government, and that may well be a different view that Lucy Whiteman and others would have a perspective on. On your point around the voluntary sector, I can only agree. I think the importance and value and contribution of voluntary sector has been so obvious through the last 6 months in the way people stepped up from all different agencies to respond and keep people safe, particularly who are shielding and at home. And I think it is an area that from a joint commissioning perspective we should look to do better at for people in the county and for our voluntary sector organisations, because many bodies, mine being one, but as you've mentioned, districts, boroughs, county councils, whole range of other organisations will provide elements of funding into our voluntary sector organisations, and many of them frankly spend far too much time trying to work out where the next bit of resource comes from or how the timing overlaps between things. It is complicated. We do have different decision-making arrangements for those things, but I think we could and should do something better around it. So I think it's a good observation.
And John, just coming in about the response to frustrated residents, and you know, I know how frustrated people get. I've worked in both local government and the NHS, and navigating your way through systems is incredibly difficult if you don't just know how to unlock the key to some of the processes. I mean, obviously, each of the individual organisations have their own patient engagement activity and communications function, and you know, I would encourage people to use that. But if that's not proving the case, and I'm sure people are coming to their local councillors in frustration, you know, each of the NHS bodies, such as the CCG, have got lay members who have got a focus on patient and public involvement. So if there was a frustration with a CCG service and one of your residents was not getting any joy from, you know, the formal process for whatever reason, I'd be more than happy as a lay member to, you know, to take that up on their behalf, as I'm sure most of my lay member colleagues and NED colleagues would in other organisations. The last thing we want is people being frustrated because for whatever reason they can't navigate their way through the systems, which are, you know, sometimes by necessity a bit bureaucratic. But some of the frustrations too that I have experienced are people don't like the answer to the question they're answering. So there is a bit of 6 of one and half a dozen of the other, but you know, I really wouldn't want anybody to not be able to put their point forward and have their responses or questions or concerns dealt with. So I think my advice would be, if in doubt and can't get through the actual process in the organisation, to use the non-exec director community, which are all, you know, all very widely publicised on websites.
Thank you.
Thank you very much for that. That's a really interesting and worthwhile point there, Bev. I think that's something that many people perhaps don't appreciate, and we can help steer them your way from time to time, maybe when that's required. So time is moving on. I've got Jill Mercer next, and then we'll probably look to try and conclude this item after that.
Thank you very much, Chair. Toby, one of the things that you've mentioned is to do with the funding. And also, I think it was Councillor Clark that mentioned about the growth area. One of the things that we see as councillors is when building new estates, large housing estates, etc., are being built, we're always concerned that there won't be sufficient GP services. And we have obviously things like Section 106. I don't know quite how that comes in with the funding, whether that's just an extra to the funding. But one of the things that we've been frustrated with over the years is that when these applications come forward, we ask for the CCG to say if they would require funding for extra GP practices, etc. And we quite often don't get an answer. So we are then told that we are not able to put in a bid for that money because the CCG haven't come back to us. So is that perhaps, you know, an area that we need to work on, or is it something that we've misunderstood that, you know, obviously as the people are registered, you will get extra funding. But sometimes there are extra buildings that are required to locate these extra services as well, that developer money might be able to feed into.
Okay, thank you, Councillor Mercer. Kind of yes, and I'm sure there is more we could do on this. We have been doing quite a lot more over the last year around this, 12, 18 months. I don't know how excited you and others may be on this, but we've had some work between the NHS and local government, particularly district and boroughs, from a planning perspective. We're appointed into a joint role that was a joint planning officer post. in order to do some very detailed work looking at population health change, areas of housing development, things that we know are in the pipeline from a development perspective where we've got big areas of new housing coming on stream, and also to look, and there's a number of these areas at different parts of the county where we've currently got Section 106 funding as a result of existing schemes that are either built out or partially developed. And how do we make sure we get that resource invested into the things that it was meant to be put into? It's tricky because this 106 funding tends to be primarily focused on capital, so in terms of building cost associated with either a new surgery or an extended premises. The revenue cost of implications of that capital build is something that sits from an NHS perspective out of that £1 billion pot I was talking about earlier on, which, although it sounds like a very large pot and a very big number, which it clearly is, adding the revenue consequences of quite a few small changes into that is something where those schemes often get a bit stuck. I commissioned a bit of work through my team with that joint planning officer role about 18 months ago now, which was just getting to the point of reporting when we went into March, and so it hasn't seen public light of day yet, but will shortly. And this looks at a GP premises estates strategy across the whole of the county. And it looks at bringing together those things we've just described. It looks at existing building condition, because we've surveyed all of our current premises. It looks at areas of population change, and it also looks at areas in terms of comparing their overall floor space, as well as opportunities with things like 106 funding. That should be coming out into the public domain in the next month or two, and hopefully that will go some way to answering some of your questions, because it's trying to get on the front foot of looking ahead a bit more. Happen to know from a personal perspective, I trained and started off my career in local government in a town planning office. I know a little bit about how things like that work, and I think we have missed a trick at times, not just in Northamptonshire but elsewhere in the NHS, of making the most of those opportunities. And as you say, given the scale of some of the house building that we've got, assuming the economy kind of picks back to a point that allows that to be built out, we need to do better at planning ahead on some of those things. But we have made that joint planning officer posting. I think Stephen Marks, who's been working in that role over the last year, has been really helpful because it's brought together two of those different worlds.
Can I just come back on that, Chair? We had noticed that there was some movement, and that so we were getting very full replies that were very helpful to us. That seems to have fallen off in the last week or so. But we have also in my patch lost a doctor's surgery, and there's another one that I know of. It's actually out of county, but it's affecting residents in this county. So obviously, we are concerned that we're not losing practices, and in view of the fact that we have so little public transport in our area, that people are going to struggle to be able to get to services.
Chair, if I may just briefly, if there are particular areas of concern or particular surgeries that members of this committee in different parts of the county want to follow up with myself or with Bev on directly afterwards, more than happy to pick that up if there are particular areas that, and particularly that point about things having fallen off the last couple of weeks, I'll follow that up with the team to try and understand why that may have been. Thank you.
Thank you.
Thank you for that, Toby, and thanks everybody for all the questions, and we've given this item a really good airing, I think, for the last, must be an hour and a quarter or more. We're due to move on to our next item now. Just quickly check. And Jonah, you said you might want to come back with something. You haven't put your hand up, so I'm hoping that's not the case. Great, thank you very much for that. So thanks, Toby, and thanks, Bev, for being with us. Really appreciate your attendance and the answers you gave. I should just clarify, Toby, I think John's comment about it's taken a year to get to this point was more a problem with us than a problem with yourselves and your colleagues. It's us not getting our ducks in a row. So thanks for being here both, and thanks for the offer to come back again. And if you've got other things you need to be doing, please feel free to go and do them. Thank you very much. Okay, bye. So members, we have got Kathy Hadley and Fiona Baker and Barry Scarr, and I saw another name there, Emily, I think I saw as well, with us now for the item on children's first budget. We ought really at the end of this, I'm sorry to say this, at the end of this item, agree some comments and outcomes and so on. Is everybody happy that we do that after we've taken the children's item, or do you want to do that now while everything's fresh in your mind? Somebody speak and say something, one way or the other.
Your trajectory.
Happy to do it after, Chair.
Okay, that's great. Thanks
Move
for
on
that.
to the children's first item.
Let's do that then. And then we'll also have to return to the work programme, I'm afraid, as well. So welcome, Kathy. Welcome, Barry. Welcome, Emily. Welcome, Fiona. Thank you very much for being with us today. We've asked you here to talk about progress with the delivery of the 2021 Children First budget. There may be other things that come up in the conversation, but they may be things we might want to be covering in a future meeting. So if we stray too much into things like the Children's Trust and arrangements there, I may try and steer members back to what's on the agenda today. Well, I will try and steer members back to what's on the agenda today. So perhaps if you could just talk through very briefly the report that you let us have, emphasise any points you want to emphasise, pick out any highlights you want to pick out, and then we'll get on to questions. Who's going first?
I'm quite happy, Barry, if you want me to present.
Certainly, Kathy.
Okay, just jump in, Barry, if you feel as I'm saying something or missing something. I mean, to be honest, we're sitting here in front of you actually talking about a £1 million underspend at this period, and it's a net favourable movement of 1.4, almost 1.58 million since the forecasted position in period 2. And so that's actually an extreme change to where we were this time last year. Now, there are some there are things that have happened in terms of additional payments for unaccompanied asylum seeker grants and changes for the unaccompanied asylum seekers care leavers. So some conditions that have changed in terms of more finances that we've received. But there has also been some significant work in terms of managing our external placements use of 380k. And some over accrual that's been released of 235k on external placement costs. But equally, the underspent, there are some issues around COVID and the impact of COVID, which also may have put us in this position. And so obviously, it's a good position to be in. So, you know, we've got a forecast underspend of 100k, but that's probably due to COVID and less transport that workers are using. So there's a mixture of reasons why we're in this current position. It is a favourable position, and we are looking at how that will be impacted as we go forward in terms of COVID. We do have some risks to it. Our external agency placement position currently indicates a forecast underspend, but obviously further work needs to be determined whether that is sustainable. There has been some work around our framework with our providers of external placements. And I know, looking at other local authorities' performance in the increased costs that they've had to endure during COVID of things like up to almost 20%, Northamptonshire has only had a slight increase of 3%, which is due to the fact that we kept our housing order pre-COVID, and the framework that we have with providers has given that opportunity. We have parent and child residential placement costs are presenting a little bit of a pressure, and some of that is about not being able to move people on because of the COVID and social distancing. And so we need to review whether there is the ability that before COVID, we were actually reducing our costs around parent and child, but obviously they've gone up because people have been stuck in the system, really not able to move on from those placements. We've also seen the Educational Psychology Service has had a massive increase in the volumes of statutory work required, and so that we have had to utilise their capacity to meet that demand, which means they haven't been able to give us an income which they normally would. Obviously, we then have a 6.5 million exposure in terms of COVID that we've projected, and looking at things around the surge of referrals that we might have into the system, the complexity of need, that during lockdown, didn't become apparent for one reason or another. We've also had school closures. They're one of our biggest referrers, and even though they've gone back to school over the last 3 weeks, we've still not seen the same amount of referrals as we usually would from them. And I think that's about them getting used to the COVID environment and the bubbles and everything that they're working to currently. And so we have also, to manage that surge, we've predicted the number of staff that we may need, and predicted the number of referrals that we may be expecting over and above those that we would have. But what we are seeing is the complexities of cases being quite more, and so our need to actually give people more support is going to cost us more money. We have some challenges around our finances in terms of savings. A lot of that is around COVID and the inability to work with other agencies, and also sort of having cases stuck within our children in need because our partners perhaps aren't doing the work that we need them to do to move families on. So our savings shortfalls will be for improved children outcome, reduction in residential care, disabled children's review, health obviously are distracted by COVID, as they should be, and so our ability to talk to them about how we can manage our services differently with them is a challenge. We also had a reduction in applicants for foster carers during this time. We have continued to do assessments, but they have absolutely reduced. That is now beginning to pick up, and we do have more assessments in the pipeline, which has also hindered our ability in terms of placements and placement sufficiency. Just looking, so additional home care support during school closures has had an impact. We've had less children leaving our care, our restriction on placements moves for those who are all rights exhausted, all those young people with all rights exhausted. Although we have seen the number of looked after children in care drop. At our lowest, we were 1126, but we're now back up to 1156, and that was so we were having children leave the system. We weren't having many children coming into the system. During COVID, we've been very successful in moving children on to either family members, but also moving them on in terms of adoption. So all of that work has continued during this period of time. I've talked about additional staff costs that we will need, and equally we will have lost the income for any penalty notices for unauthorised absences for schools. That's a run through of the presentation that you've been given. I hope that was enough, but happy to take any questions, or for Barry or Emily to furnish you with some more information if there was anything they feel that I have missed.
Thank you very much for that, Kathy. Fiona, is there anything you want to add to that?
I don't want to add to the finances, because I think Kathy and Barry have put together a very good report to give you our position on that. But I do want to say that we should expect there still to be more cases coming forward. It's been slower than we thought it would be, because schools have been back now for 3 weeks. But this is a worry that there will still be children out there that we don't know about that will bring costs upon us. So we do need to be aware of that. And just on a very peripheral note, we are advertising on social media all the time for foster parents, and anybody who is on social media, I'd be really grateful if you would share it around to everybody you know, so that we have a very good coverage of these adverts going out. Thank you.
Sorry, thank you, Fiona. And yes, something worth doing for those of us who tweet and do other social media stuff. Okay, so questions. I've got the Councillor Jim Hatepool first.
Thank you, Chairman, and thank you, Kathy, for the outline. On the paper you've given us, paragraph 4 starts a targeted approach. At the end, it says the project has seen initial success, a reduction in the external placements forecast of 380k, but it doesn't say what reduction. I don't know if Barry or Kathy can come back on that. You know, a reduction could be £5,000 or £100,000. And what are the predictions based on whatever your answer is to that for the end of year, end of NCC finance for that aspect? Thank you, Chairman.
Can I just have the indication of which paragraph, because I've got two papers in front of me. Which paper are we?
It's the one that we got in our pack. It starts forecast variance 0.999 million. Net budget 127 million.
Yes, yes. Oh, sorry. And so which
4.
1, 2, 3.
Starts a targeted approach after the unaccompanied asylum seekers. I'm sure I've got the right one, agenda item 8.
So under variance highlights, unaccompanied asylum seeker grant income includes an additional 1 million in period 4.
Yeah, it's
next paragraph, I think, Kathy.
Reduction in external placements.
Yes, the project has seen initial success contributing to a reduction in external placements. It doesn't tell us what the reduction is in terms of volume or value. And my question would also be, how do you see that panning out at the end of the year? What was the reduction in the forecast of 380k? Thank you, Chairman.
I think, Chair, this may be just the way that paragraph reads. There is a reduction of 380,000. Yeah. It's not a forecast of 380,000. No. I think it's just the way that it's been written and read. Yeah. So to be clear, the reduction is 380,000.
Yeah. And that
on what overall total budget?
The external plate
is less than what?
Sorry, the external.
Sorry, it does read a bit that way. Apologies, Chairman, if I've misread it.
The external placements budget is circa £50 million. So we're forecasting a reduction due to price negotiations. So it's not volume related at the moment, it's due to price negotiations. Obviously, we'll continue to monitor that throughout the financial year and hope to see further improvements linked to those price negotiations in future months. But those will be reported to Cabinet as and when.
Sorry, I just missed the total figure, Emily.
So it's circa £50 million is the total external placements budget.
Thank you, Chairman.
Thank you very much, and thanks for that, Emily. So next, I've got Councillor Jane Birch and then Jonah Roy.
Well, thank you, Chair. If I may, not entirely financially targeted questions. It's more to do with the delivery of the service, Kathy. Yep. That's right. One is about the new babies that have been born during COVID and the parents, families that support that they might have been, that might have been delivered to them. And the other, you've touched on the educational psychology service. I understand there's been quite a lot of churn within the staffing in that area. I wanted to just ask you if the staffing was fully up to, up to the need at the moment, and there has been an ongoing impact in the schools as they felt some kind of uncertainty over this change in the sort of working of the service. So two questions there: new babies and the educational psychology service, which I think is going to be really, really in demand in in our coming sort of months and years. Thank you.
Absolutely. All parents that are known to our service, obviously, with new babies, because of some of the very sad situations that we've had during the COVID period, we have worked with our partners to have a local response. There's also a national response that's happening in terms of, because it wasn't just related to Northamptonshire, a national response to the safeguarding of children, especially babies. And obviously that's around parental oversleeping due to drugs and alcohol. So we have worked with our partners for a local response to that. But what we've also done in terms of our internal services is that anyone that has a new baby, we now have a specific assessment and an alert in terms of how we manage those young parents or new parents, especially those with drug and alcohol issues. What we also need to do with any new babies of those that are not known to our services is for our, our midwives and our nurses out in the community to be aware of those families. And, there has been an element of during COVID, some of those services have not been present. And so we have so that has been raised within the partnership of how we manage that. And if we go back into a second lockdown, what will that look like, and how will we manage that as a partnership? Because that's something that was quite a challenge in terms of identifying vulnerable mothers that we were not known previously to us as a service. So that's the work we're doing there, and there is a national response to that as well. In terms of the educational psychology service and the SEND service, the staff group, as far as I'm aware, are reasonably solid. I think what you may be referring to is that we have a number of vacancies in that area. Educational psychologists, it's a national issue in terms of recruitment. They're not easy to recruit to. And so we have the same problems as everyone else. So we have a vacancy level, but equally the requests for assessment have gone up so considerably that in terms of our capacity to manage those in a timely way is being reduced. And so therefore we have to look at how we create capacity and efficiencies. And one of that is that we have removed some of the income work that those educational psychologists would do. Going forward, I'm working with the service to look at ways of doing things differently and putting together a business case of looking at how we can increase the number of educational psychologists, because we would all want to, going forward, seek the income generation that other local authorities have and enjoy from that services, and that's what we would want going forward for both new councils as well.
Okay, thank you very much for those answers, Kathy. Jane looks like she's happy. Councillor Anjona Roy.
Thank you, Chair. Again, this is more an issue around service delivery rather than performance, rather than finance. I've had quite a few constituents and other people coming to me in relation to school transport. I realise this isn't your area, given that it's from the Place Directorate. However, a number of them have had difficulties securing school transport in a timely manner because of delays in putting in place educational and healthcare plans, and being assured that actually the delay in the educational healthcare plan being put in place wouldn't be a problem in terms of securing school transport. And then when the time came, they're being denied school transport for the whole of that first half term. I just wondered whether this is a capacity issue or a COVID issue. And I also wondered whether you'd looked at means of trying to circumvent that problem. So I know other authorities have a transport section or any other issues section on the educational healthcare plan, so that the needs for transport or any other issues can be clearly stated. So is it a capacity issue, or is it a COVID issue, and are there ways that we can get over this? And have you looked at things like what other authorities are doing in terms of educational healthcare plans?
Okay, I don't think it's a capacity issue. I don't think it shouldn't be a COVID issue, because if a child is identified as needing school transport, then they should receive it. I would have to look at the examples. So if you can give me some examples, I can go away and have a look at that. I think it was a challenge for our transport colleagues in place to manage the multitude of DfE guidance that came at them from the beginning of the lockdown to when they were supposed to step up the transport to actually put it out there by the time we got to September, was a movable feast. And I know that lots of local authorities struggle with that. And in the main, there were a few issues around some of our transport, but in the main, I think they are now all resolved. But if you could send me some of those issues, then I will definitely have a look at them for you, Councillor Roy.
Lovely, thanks for that, Kathy, and Jonah's pleased with that, so that's good. So she'll be in touch with you. Jane, you've still got your hand up. Is that you wanting to come back in, or will you take it down? If not, lovely, thank you very much. In which case, Councillor Jill Mercer, please.
Thank you, Chair. This 6.5 million for the COVID financial exposure, I just wondered if that was reclaimed from the government under the sort of COVID finances, and whether it's likely that we will be able to claim back the whole of that monies, and Barry might be able to help with that. You know, or how that compares to the grant. Are we going to still have a shortfall?
Sorry, I'm not sure if Barry caught that. I mean, that is the 6.5 million is the figure that we have calculated in terms of thinking of what the service may need. I would have to lead to my esteemed finance colleagues Barry or Emily to outline how we would claim that back and what funding that we've had actually from the DfE already to be promised.
Sorry, Chair, what was the question again?
So will we be able to claim back that shortfall of the 6.5 million from the government under the COVID finance?
Right, so in terms of COVID funding at the moment, we have a surplus of COVID funding. So we're retaining that, as you'll see in the monthly finance report, for the recovery phase of COVID. We're not pressuring the government to give us any additional COVID funding at the moment, but we obviously are waiting to see what the results of the obvious second wave of COVID in September, October is going to produce as well. So at the moment, we're in a fairly positive position of having more money than pressure, albeit that a lot of the pressure that's building will build in next year in terms of a collection fund. So we might have to hold some of that money back. But I'm not in a position where I'm thinking that there is a big deficit on COVID funding at the moment.
Thank you.
Thank you very much, Jill. Not seeing any other hands up at the moment. So in which case, I think we can say thank you very much to Fiona, Barry, Emily for being with us today, and to Kathy, and for answering the questions that were asked. And on the subject of the trust and the arrangements there, I think we'll all have heard what's been said, for instance, by the Chief Executive about what she would like to see Scrutiny do. And I gather that's going to come to fruition fairly soon. And colleagues, councillors, we may talk about that in a short while. So thank you all for being with us. If you'd like to go and do other things, that's absolutely fine. Thank you.
Thank you very much.
Thank you.
Through you, Chair, were there any conclusions or comments the committee wished to reach on this item, or is it simply a case of noting the latest position?
Thanks for that, James. That's a good prompt. So, colleagues, anything that we want to identify, comment on, recommend, send back to Cabinet, or are we just noting what we heard so far? Jane Birch.
Thank you, Chair. Just bearing in mind what Barry has just said about the COVID funding, I'd like to know exactly where those funds have gone, and particularly in case of children's services, because that's a really big area of demand. He was quite. I didn't seem to feel that we were going to get any numbers from Barry, and perhaps Barry would like to provide those at a later stage. Thank you.
I'll just say in response to that, Chair, the full position in terms of business as usual budget and COVID budget is set out in the regular monitoring reports to Cabinet. That went to the last Cabinet, so all councillors can see that on the committee services system. All the figures are in there if you want to see them, including what we spent on COVID, what the funding is, and what the surplus is as well, across each service, not just children's.
Understood, Barry. Yes. So I think, Jane, if there's anything that you want any guidance on, there are many councillors who are happy to offer guidance at the drop of a hat, and no doubt officers who would help you too. So hopefully that's going to be useful to you. I've got Councillor Jim Hakewell now.
Thank you, Chairman. It relates to the point I asked. I still read it, not sure whether it can be read two ways, but initially when I read it, I thought 380k reduction in placements was brilliant, when we have financial data, we should have the 50 million overall budget shown as well. Because if you take 380k out of 50 million, it's good, but not amazing. If you saw it as 380k, you'd say that's fantastic. So when we have financial data presented, can we have the total amount that is being taken, and even better, a percentage, just so that we've got real facts to go on rather than a bit of speculation, which I caused.
Thanks for that, Jim. I think Barry himself acknowledged that perhaps the paragraph could have been better worded. I think you're right, you know, extra information like what percentage of the total budget has been saved and what the total budget was is always useful. No doubt that's taken on board. So I've got next Councillor Michael Clark.
He needs to unmute himself, Chair.
All right, Councillor Clark, we think you're muted.
Yep,
You're
sorry
not
about
now.
that, Mr. Chairman. Okay, that's in full flow. I was just going to say I was impressed by a sentence that Cathy Hadley spoke early on when she referred to the overall underspend that was forecast, and she said that they had kept the house in order pre-COVID. I thought those were very telling words, Mr. Chairman, because looking back on this directory historically, we've had problem after problem related to overspends primarily, which go back years and years, and it has not been for lack, as everybody's agreed, of lack of resource which has gone in. It's somehow the way that it has been applied. And I've noticed, certainly in the last, what would it be, 8 year to 18 months, there's been a radical change in the way that this department, this directorate has been run. And I feel it's been a positive change because it's been a certain amount of, I think realism breaking out, that we have to cut our coat according to our cloth without jeopardizing our services. And I think with the numbers of unallocated cases having come down dramatically, and I think Councillor Baker's reported it's been down to 0 for the past, 4 to 6 months, having been one of our Achilles heels with Ofsted. This is, to me, a mark of progress and better management. So coming back to your words, Mr. Chairman, of noting this report, certainly I am much more encouraged by the direction of travel under Cathy Hadley's leadership here, and Councillor Baker as well, as compared with the problems that we've encountered in previous years and the difficulties which have contributed to many other problems at a higher level within the council. Thank you.
Thanks for that, Michael. Cecile, you want to say something?
Yes, thank you. When we speak about numbers, and Barry Scarr presents them very well, but in the world of children or even adult, it's all depend. We are demand-led, and Cathy was quite clear that with COVID-19 there is a lot of unknown that might come out after COVID-19. So for me, for us at Scrutiny, I would like to have a bit more visibility if there is something that goes a bit off piste. Could we have a pre-warning and very clearly the impact on the bottom line, but also because we had health. For example, Cathy mentioned the co-sleeping and so on. All those little things that we don't know and we know after can have a huge impact on our bottom line. So could we have a bit more warning? And I don't know if Barry can comment, but it's comfortable because we looked at what we have spent. But I would like to have a sort of a traffic warning if they think there is something in the future that can be damaging to our reputation. Thank you.
Is there anything you want to say about that, Barry?
I would say, Chair, in terms of the way that we're analysing it, I'm just talking about the financial impact at the moment, not the service impact. That we do this on a monthly basis. We look at the business as usual budget, which is an estimate of what would have happened had COVID not hit. And then we separately analyse the COVID impact. So we're constantly reassessing that impact. And at the moment, there is a significant amount of money set aside for children's services, impact of schools going back, and impact of demand in the system that we haven't yet met. As soon as that manifests itself, then I will release additional COVID funding into that, and that will come through in the revenue forecast. Now, I know it's difficult at the moment because we moved away from monthly cabinet meetings, and that could take until November for it to come through. But certainly, in terms of organisation and internally, we will be reporting that through NLT and the regular meetings that we have with commissioners if that does become a high level impact on the budget.
Lovely. Thanks for that, Barry. And thanks for sticking around to hear those comments and offer further clarifications. I'm not sure we've identified any specific comments we want to make, or issues arising, or indeed matters that we want to consider for the future. So if everyone agrees with that, are we happy to just note this report? Just show of hands on that, please. That's great. Thank you very much, everybody, for that. So in which case, thanks, Barry. We'll move back to the health item and just quickly cover off whether we wanted to do similar on that. So what we need to look at is, are there any comments or recommendations arising from the agenda item that we wish to make? Are there any issues arising which we wish to request further information on? And are there any matters arising from the item that we wish to consider as topics for future scrutiny? And if so, how best can we do the work? Anybody? Councillor McGee, then Councillor Hakewood.
Thank you, Chair. I appreciate that. I thought that was a very good hour and a half or whatever spent on that. It was a good opportunity to find out what was happening and ask questions. Can we follow up, Chair, on my request of joint commissioning for the voluntary sector? Whether that's through how they're going to do it, how it's going to start, or, you know, I don't wish to be cynical, but we sometimes get a positive answer and then we don't hear anything for such a long time. So perhaps, Chair, if we can ask for the next meeting of an update of how they've progressed, that would be helpful.
John, do you mean joint commissioning between the health service and the voluntary sector?
I mean joint commissioning between all the possible public bodies to look at how they can joint commission the voluntary sector together. Because, Chair, public health are going to be doing a lot of cuttings before March, and unless we pull the services together, we will lose some of our valuable prevention voluntary sector.
Okay, I'm sure we can have a look at that and maybe determine who we might ask those questions to. Perhaps we can return to that at the pre-meet next week, James?
Potentially, Chair. So it sounds in the first instance as if the committee is asking for a bit more information about what's being done in the direction of joint commissioning of the voluntary sector.
I think that's what John's getting at. He's just got his hand up again.
Yeah, I think James is going along the right roads there. It's what they're doing now, and actually Toby says that he agrees with what my aim is, to try and get more organisations to come together to fund it rather than just social care, because it affects CCGs, NHS, everybody else. And he agrees and said he would look into that. I just don't want him to go away and forget about that and come back to us and say what he's going to do about that.
I'm sure we can make sure he stays on task and provides the information, John. Jim?
Yes, just to reiterate my point about exemplars where health and social care somewhere in the country have come together and achieved the aspirations that we often talk about with that closeness. I think perhaps the same thing about children's. And the thing that always strikes me is that with virtual meetings like this, if there is a brilliant example in Durham and a portfolio holder or an officer there, that we can actually ask to say, you know, can you be with us at 10:15 on Wednesday or whatever? A, I'd like some exemplars of where these things work, adult, social and children's. B, it would be great, Scrutiny, to be able to talk to people in our similar position that have either succeeded or failed or both. Thank you.
And the challenge would be, of course, to link such a thing to our finance focus. But I'm sure we can find a way.
Thank you, Chairman.
So, yeah, so James, yeah, go on.
Sorry, through you, Chair. So in essence, it's asking for some briefing information about exemplars of where health and social care services have been integrated effectively.
From a financial bias.
Sounds like it.
To achieve effective financial outcomes.
Indeed. And hopefully you got John McGee's point as well. Yes, good, lovely. So no one else with hands up. So that looks like we've covered everything we need to there. So we'll move on to the work programme, which the bit you've been waiting for.
Chair,
Oh,
I
Jill,
just put my hand up, but sorry, I was a bit late.
Oh.
I thought it was very worthwhile, and I think it would be useful to get an update at some point in the future of because we really have neglected health, and you know, it was really useful to catch up on various things, but it was quite a whistle-stop tour. So I think you know, to repeat that if we can sometime in the future would be useful.
I take the point. I think the challenge might be to find a time that we can do that, and it may be that to the next round of sort of scrutiny challenge to the health service in Northamptonshire will be by the scrutiny panels of the shadow authorities for their particular areas, given the geographical split and also the implementation of things like PCNs. I think they sound like a really good thing. And you know, I'm sure that, for instance, the shadow in the north will be wanting to look at how the PCNs are working in the north, and no doubt the west the same. Yeah. So I think you're right that it needs to be revisited. It's just a question of who's going to be doing the revisiting.
Yeah, if it has to be the unitary, then fine.
Yeah, just on that point, Chair, I mean, looking at it in a very practical way, after today, this committee has 3 further meetings three further scheduled meetings at the end of October, the end of November and the end of January. So as an update on a substantial overview of health services, you wouldn't be looking to do that in a month's time or 2 months' time, which leaves you with 1 meeting where you might reasonably do it. And even then, that would be a matter of a few months into the future rather than a year later.
Indeed. Thanks for that steer, James. So if everyone's happy, we'll move on to the work programme now, if that's okay. It's agenda item 7. You've seen the paperwork. I think the most important thing to flag up is the thing that I alluded to, which of course everyone's aware of, which is what's been said by not just the Chief Executive, I think it's been said by others too, about the negotiations regarding the Children's Trust contract and the scrutiny of the financial aspects of that, which lots of people are keen for us to do. And that's something that's going to come up pretty soon, because my understanding is the contract is almost at the point where a negotiated draft will be agreed between the parties. And I think we're even saying as much as you might want to keep the 21st of October open in your diaries as a possible date for that, given that our next meeting isn't until the end of October, and if the trust is due to start at the beginning of November, we wouldn't really have time to scrutinise it, make comments, and for those to be taken on board before things get signed up to. Would that be a fair summary of where we are, James?
Yes, I think so, Chair. There's a willingness for the committee to do it, but it's to a very tight time scale. And yeah, the scheduled meeting on the 28th of October would not fit in with that.
Okay, so there's that. Other things on the work programme that might be worth noting. Firstly, that we had requested some off-agenda information about our highway services contract scrutiny review. I think we're hoping to get that before Wednesday of next week. I don't know if that's a forlorn hope or not, but we're hoping. So it might be something we'll be able to cover at the pre-meet next week. I think there's a valid point to be said. There was something in the work programme about a further survey of members' interests and expertise, and there's probably very limited value in doing that now, given the time we've got left. So we'll, if everyone's happy, that probably come out of the work programme. That said, on finance matters, whilst the NFR that was at the last cabinet projected an underspend for at the end of the year, if you have a look at the report, flagged up throughout the report are various risks, and our focus might be on pursuing how those risks are being addressed and whether any of them are having an effect on the projection. So that's my thoughts. Anybody else got anything they want to say about the work programme?
So, Chris, my hand has disappeared.
That's right, Councillor. I can see you, Victoria, so please speak.
Yeah, I think we can be pretty certain on the deadline of the 1st of November. I've had a copy of an email that's been sent to all the staff in Children's First, alerting to them that the likelihood is 2P will take place on November the 1st. So with all the financial considerations for them as well, that's already detailed. So I think that meeting on the 21st is going to be our only opportunity. It looks like it's pretty much going to be the 1st of November. So we need to be on that.
I absolutely agree, and I'm sure we will be on that. And the steer we've had that we ought to be on that is something that should give us motivation. Councillor Hakewill, you've got your hand up.
Briefly, obviously we're not going to be this year scrutinising a budget because there will be no NCC to scrutinise. But is there anything between ourselves and West and North scrutiny? I'm sort of, the vision I have is handing over the baton, whether there's anything on our work programme that we might invite both West and North to join us or something in that way to hand over. I know some of us are on both. It was just a thought, it wasn't a determination of a particular item.
I think that's something that might be worth pursuing, but possibly in a quite an informal manner. You could have a word with the Vice Chair of Scrutiny in the North and see what she thinks about that, for instance. And other things as well. But yes, I agree. The baton needs to be handed over most definitely, and those members of Scrutiny who are not on the County Council scrutiny function need to be aware of our concerns and where we're at, and I'm sure they will be made aware. Councillor Michael Clark.
Thank you, Mr. Chair. Just briefly on this question of the Children's Trusts, and I think taking note of what the Chief Exec said, we've been warned off in getting involved with the contract negotiations. However, sooner or later, the budget for the Children's Trust will come into the public domain. I don't know, perhaps James can help us as to when that will be. It strikes me, though, we have a lot of expertise within NCC and in present company included in dealing with our own Children's Directorate budget over many years. I think it would be helpful to the colleagues that are coming onto the unitaries, some of whom are here today, if we could provide some input and ask some pertinent questions as to how certain figures in the Children's Trust budget have been arrived at. In other words, to, if not to scrutinise it, but to stress test it and try to tease out what might be weaknesses, because, you know, forewarned is forearmed. We want this Children's Trust, in the interest of the children, the parents of the children we represent, to be a success. And the devil's in the detail. And I feel that if we can, as councillors before the end of NCC, bring some of our expertise to bear to test what has been assumed in that thing and be assured that it's going to get the best possible launch possible and things haven't been overlooked. In other words, if stones have been unturned, which deserve to be overturned, let's do it. Have we got an opportunity to do that in any of these meetings?
I think we will have. James, you look like you want to say something there.
Oh, I'm not sure I intended to give that impression, Chairman. I would hope, at least in part, that an overview and scrutiny committee meeting in October serves that purpose. To the committee's been given a very clear steer that the development of the Children's Trust in broad terms is not within its remit, but there is a role for it in scrutinising what have been referred to as the financial aspects of the Children's Trust contract. Councillor Clark's comments would seem partly or wholly to fall within the financial aspects of the Children's Trust contract. It's worth highlighting that there's a job of work to be done around the practical arrangements for scrutiny on this, translating this task into an agenda and the supporting material you need to be able to do scrutiny of this. But yeah, that will hopefully be, it should be assisted by the fact that there, as the Chairman's highlighted, there seems to be a clear will that scrutiny should be able to do something on this.
With your permission, Mr. Chairman, could I just ask a supplementary of James? Do we have any steer? Sorry. Do we have any steer when this budget is likely to come into the public domain, that we can receive a copy of it and start to peruse it?
I don't think I'm in a position to comment on that. It's getting outside the area I have any particular knowledge.
Could you ask the question?
Can I help, Michael? Maybe a little bit anyway. I think the answer that you would get from finance officers, if they were still here, would be that the budget of the children's, or the budget of the service areas that are being passed over to the Children's Trust in the current financial year will be the budget that was set by this council at the beginning of the financial year. That's the budget they're going to get, and then they will perhaps ask for extra money, and there may be something in the financial aspects of the contract, which we're going to look at in October, that alludes to that. I think what we're going to be seeing is something quite broad brush. I don't think we're going to be looking at the nitty gritty of pounds, shillings and pence this in October. But as monthly finance reports come forward to Cabinet in future months, and once the trust is up and running, and if we see that if the budget for any reason is not sufficient, you'll see that as a pressure in the monthly finance reports to Cabinet, and we'll be able to ask as many pertinent questions as we want to at that point. Does that sound reasonable?
Well, if I could just come back to you on that, Mr. Chairman. Yeah. You said the current budgets which we've approved in February will be passed over to the Children's Trust.
That's my understanding. For the bits of the county council that the trust is taking on, not necessarily all of the children's service budget. Yeah.
Well, quite. That was my question, Mr. Chairman. That it's not a lock, stock, and barrel transfer. The county council will, as I understand it, until we move to unitary, still have responsibility for the LEIA side of things. The administration of the primary schools, which are still in our bailiwick. What we're passing over to the trust will essentially be the looked after children side of things. Is that correct?
You're asking me questions I don't know the answer to, but I'm
sure we'll find
out. So that's something we're going to look at in October. Has anybody got any other items they want to add to the work programme? And is everyone happy that we take out of the work programme the survey of councillors' expertise? Not hearing any dissent or any suggestions either way. So, James, have you got that such as it is?
Yeah, thank you, Chair. So the committee agrees that it will seek to look at the Children's Trust contract financial aspects during October, and that line in the work programme about the survey can be removed.
I think that's agreed. Everyone happy? Look at that. Excellent. There's no urgent business, no exempt items. I think that brings us to the end of the agenda, unless I've missed something, James.
No, you're correct, Chair.
Michael, you still got your blue hand up. Did you want to say something else, or is that's residual?
He's just
brilliant.
Old.
I'm going to say you've heard quite enough from me, sir.
And me likewise. So in which case, thank you everybody for your attendance today. I hope you had a fun time. See you all soon. Thank you, James. Thank you, officers.
Thank you.
Bye.
Well chaired, Chris.
Thank you.
Bye.
Bye.
Bye.